May I next call upon Dr. Orbital cerebral mucormycosis.
Thank you so much, respected Chair, and good evening, everyone. I'm going to present my study on ocular blood flow in patients of mucormycosis. Mucormycosis, we all know, is an angioinvasive fungal infection with high mortality and morbidity, and that has been increasingly reported in patients of diabetes mellitus, malignancies, organ transplants, and corticosteroid therapy. Especially during trailing end of second wave, we saw a dramatic surge in the number of the cases, and it leads to tissue infarction and necrosis of retroorbital space and subsequent orbital apex syndrome, leading to various ophthalmic manifestations like total ophthalmoplegia, proptosis, and loss of vision. When we searched the literature, what we found that there was no documented study to document the ocular blood flow and occlusive pathophysiology of the disease, and there was no correlation of inflammatory blood markers with ocular blood flow. So with the aims, we did this study to compare the ocular blood flow parameters in the patients of ROCM in both involved and uninvolved eye, and also to correlate these parameters with inflammatory markers of the patients so as to gain insight into the disease pathophysiology. This was a hospital-based cross-sectional study where 91 cases of mucormycosis were checked, admitted in GSVM Medical College Kanpur. Out of which 17 cases of biopsy confirmed mucormycosis, in which one eye was involved and the other was not involved, were included. This was approved by Institutional Review Board and informed consent was taken. Now, detailed history and examination was done for all the patients with regards to best corrected visual acuity, IOP, ocular movements, and so on and so forth. And diagnosis was confirmed by KOH mount and biopsy taken from the middle turbinate of the patients, which was sent to microbiological lab of the institution. This was the sonocyte machine on which color Doppler flow was checked for these patients. Now we can see it was primarily done for three arteries: short posterior ciliary artery, ophthalmic artery, and central retinal artery. We can see the graph. The trough of the graph is the diastolic velocity and the peak is the peak systolic velocity, and resistivity index is automatically calculated by the machine. Here we can see the reduced peak systolic velocity and diastolic velocity, and in this photograph we can see that there was no blood flow, and we can see a small emboli occluding the central retinal artery. So in results, out of 17 patients, majority were male. 8 patients were PL negative at the time of presentation in the affected eye. The best corrected visual acuity in rest of the eye was 1.3 plus minus 1.3 logMAR unit. Best corrected visual in uninvolved eye was 6/6. Now this is the involvement of the muscle. If one muscle was involved, the number was given as 1, and for 2 it was given as 2, and for 3, and for 4 muscles it was given as 4. If all the muscles were involved, the number was given as 5. Majority of patients, they had 2 muscles involvement, 35%, and here we can see 3 muscles were involved in 29% of the patients. All the patients were post-COVID and all the patients were diabetic, and they out of these 60%, almost 60% patient, they had history of steroid usage. Now the mean age was 50 years of age. IOP in the affected eye was slightly higher than unaffected eye, but the p-value was not significant. Now this is a slightly busy slide which is showing the various ocular blood flow parameters in central retinal artery and short posterior ciliary artery and ophthalmic artery. We can see very clearly that peak systolic velocity in affected eye was much lesser, around 4.13 millimeter per second square in comparison to unaffected eye. Similarly, when we see the end diastolic velocity, it was significantly less than unaffected eyes, and p-value in all the arteries were significant. So this is the same graphical representation. The mean of ferritin level, inflammatory markers were also checked. So mean of ferritin level was 710. Hemoglobin was lesser, 9.69, and TLC was 9,500 in our patients. MCV being also near normal, 70. Only the ferritin levels were very, very high. When we tried to correlate with the ferritin levels, it was seen that it correlated with peak systolic velocity and end diastolic velocity of central retinal artery and short posterior ciliary artery, not with ophthalmic artery, and there was a negative correlation with hemoglobin values. So, this mucor has affinity for the arteries, and it grows along the internal elastic lamina, and they cause thrombosis and infarction. So, mean reduction in ocular blood flow parameters confirmed that there was vaso-occlusive disease. Increased ferritin concentration indicates an increased baseline storage of iron in such patient, and that has been seen in other studies also. Now, because there was a positive correlation with the ferritin levels and negative with hemoglobin, that again indicated that there was invasive fungal invasive infection in retroorbital space. The limitation of the study was small sample size, and other inflammatory markers were not estimated. So to conclude, I would say that vaso-occlusive pathophysiology was documented by measurements of ocular blood flow parameter, and increased ferritin levels indicate more invasive nature of the disease. Thank you so much for your kind attention.
Thank you, Dr. Mohan Shalini. Just a question. You measured the OBF. Now, did it change your management depending on the blood flow?
So, in the patients in which the vision was not there, we simply gave them an injection amphotericin retrobulbar. And in the patients...
No, madam, my question is very simple. Depending on your study that you've done, I'm not looking at the other factors. Did it help you in determining which patient will require treatment?
Yes, in the patients in whom ocular blood flow was less, they were treated more aggressively because it reduced ocular blood flow was suggestive that they might land up in more problems. So they were treated more aggressively.
Thank you.
Thank you.